Good afternoon. I'm Jeff Miller. I'm Director at Laughlin Hospital's Respiratory Therapy Department, and I want to talk to you about one of our change initiatives that we had several years ago, and it was the developmental of patient-centered protocols. First, I'm going to go over a brief history of the hospital. Once again, I can't see this real well. But we started the first clinic, Dr. Laughlin, in 1939. He opened a clinic in a private house, and I think it was him and one other physician, and I believe they had 4 beds. It was a big facility. Later on in the 40s and 50s, they actually expanded to a 99-bed facility, which was across the road from the facility that they started. And then in 1971, we got our first Joint Commission accreditation. And in 1978, we expanded to 177 beds, which was a $3.6 million expansion. And then we had a $12 million expansion, which is the current building that we have today, which is in the middle there. And then, of course, we joined Mountain States Health Alliance this past year, and we will soon be a ballot hospital as well when they finalize in July. Okay, let's talk about where we were and where we wanted to be. When we first started off, we had this provider-driven therapy, and the therapy was typically ordered by a physician, and you kind of know the routine. You come in the emergency room doctor orders some things, sends you upstairs. Doctor upstairs just kind of continues everything, and it goes on and goes on and goes on. And finally, you go home, and nothing's happened to you since the time you came in and the time you left. You still got your oxygen on. You're still getting treatments the same frequency. And so we saw that as a big problem. And so what we wanted to do was do a therapy-driven protocol where basically the therapist comes to your room, and they assess you, and they put you on a care plan based on your protocol scores. And then the doctor just basically signs along behind you. He looks at the orders, agrees with them, and signs off on them. And that allows us to modify as we go. So the physician assessments that they were doing in the old form, they were very subjective, and they didn't really allow you to measure improvements. In the new protocols, we're using objective assessments, and we can actually give you scores. And as you improve from day to day, we can decrease the intensity of your therapy, and actually may even stop the therapy before you get to go home, so that you're not making that decision of whether they need to continue in a home basis or not. Most people are fine to stop it and go home without anything. In the old system, the modification from the therapy, you ever been in the hospital? Doctor sees you, what, once maybe a day? If you're lucky, twice, where the respiratory therapist is coming to your room 4 to 5 times a day. And so it made more sense to have the respiratory therapist follow your improvement or your deterioration, because we're there more often. We can see acute changes. If you change from 7 in the morning to 7 at night, that's a 12-hour gap that no one has really looked at you and made a decision about whether to increase or decrease your therapy, where the respiratory therapists are in there, like I say, several times a day. We can catch changes much faster that way. The high patient demands for the physician made it difficult for them to identify some things like discharge planning needs. Doctors if hospitalists might have 30, 40 patients apiece to see every single day, so they cannot keep track of everything that you need. Do you need home O2? Do you need treatments at home? It's simply too much for the physician to do, where when we turn it over to the therapist, it allows us to use that time that we spend in their room every day, and by the time they're ready for discharge, we pretty much know what they're going to need when they go home, and we can keep the doctor informed about that so that discharge planning can take care of all that. This was a plan change, obviously, promoted by a variety of quality issues. Like I said, I'm having a little trouble reading this. But patients were identified that were receiving unnecessary therapy. A lot of the statistics say that up to 40% of the respiratory therapy given is unnecessary. It started and never stopped. It started and never modified, or it started based on a disease state instead of a symptom state. Used to, everybody with pneumonia got albuterol treatments. We discovered that albuterol treatments don't help pneumonia. Antibiotics fixes pneumonia. If you have pneumonia and COPD and you're wheezing, albuterol helps. So we moved from treating the disease to treating the patient. So we treated the patient's symptoms. The other change was increased cost of care. Obviously, if we're doing 40% therapy that we doesn't need to be doing, we're driving the cost up to the patient who's getting a bill for this stuff. And we're driving the costs up for the facility who's sending therapists out and paying them and using supplies to do unnecessary therapy when they could be concentrating on other patients that maybe needed more help. Inefficiencies in the discharging plan, we talked about that, specifically discharges were being delayed with patients because they were not being evaluated for home oxygen and home nebulizers in a timely manner. Chad, are you the only one working in healthcare? Yes, I think you are probably. Anybody else working in healthcare? Well, it's typical, doctor discharges a patient, the nurse goes in the room, they still got their oxygen going at 2 liters a minute.
Yeah.
Nobody's ever turned it down. That's the old system. And so now the discharge gets delayed because somebody has to turn the oxygen off, make sure they're going to do okay without it. Now the therapists do that a day or two in advance. And typically the doctor will tell us, we plan to discharge this patient in the next 48 hours. Respiratory therapy gets on there and evaluates that oxygen, gets it turned off, or if they need it, we get them qualified to have oxygen at home. I consider this too a revolutionary change. I don't think it meets the strict guidelines, but it was just such a drastic change. From the doctors ordering everything, now the nurses were all of a sudden getting orders written by respiratory therapists. And I think Chad's been doing it in his world for a long time. PT gets evaluate and treat, and that's basically what we did. RT got evaluate and treat. It was a big change for everybody, and so I kind of considered it revolutionary. It's been done in a lot of hospitals, but for us, it went from here to here in basically one step. We didn't do a lot of intermediate steps. Now we talk about making the change, we obviously had to do some leadership and organizational support. And basically what we did is we got the support of our leadership first. And if you work in a health care facility, there's a couple of crucial steps. You have to get the leadership support first, meaning your administrators, CFOs. Then you have to get the physician support, because if the physicians bucket, it don't go anywhere else, because administrators do not like unhappy physicians because they drive the hospitals. So you get that support, and then you start getting the support of your own team. And this differs a little bit from what we talked about this morning of bringing everybody in up front. In a situation like this, I did not bring my staff in until I knew that it was a go from the administrative point of view and the physician point of view. My only theory was I felt like if we tried to make a change and announced it and then it didn't go through, that would create confidence problems with my staff and myself. Next time I want to make a change, it'll be like, yeah, last time we tried that, you couldn't get anything done. So, we're really not very confident in the process. So I made sure I had it as a approved policy before I brought my staff in. The other is nursing. Nurses obviously had a big change for them as well, because they basically have the best relationship with the physicians of anybody in the hospital. They call them all day long, they see them at the desk. And nurses were used to calling the doctor and saying, so-and-so in bed 3 needs breathing treatments. That was a change for them, because now they call us. We go evaluate and we decide what treatments they need, how frequent they need them. So this was a big change for nursing as well. And obviously without nursing support, Chad can tell you, nurses can make you or break you in a healthcare organization, because there's so many nurses. They have such a big influence in the hospital that if they don't buy into it, they can create all kinds of problems. But if you sell it to them, they can be your best ally. So what we went right with this, we secured the support that we needed from the stakeholders. For one, administration enjoyed the idea that it was quality, safety improvement, patient satisfaction, reduction of labor and supplies. We got the medical director to buy in because it actually enhanced the department that he was over. It gave us recognition and prestige. The hospitals were on board because it saved them tons of time. They don't have to sit down and write all these respiratory orders. They don't get called in the middle of the night to ask if we can give an albuterol treatment. The respiratory therapists just go and do it. Then they call the doctor later if they need to and say, so-and-so is not doing very well. This is what we did. These were the results. In the old system, the doctor gets called. He has to ask us to do all this stuff, and then we have to call him back again and tell him what happened. Oop, I'm getting my 1 minute mark. I knew I would do this. Anyway, we got all the key stakeholders. That's why it went right. Surprising what went wrong, some nurses didn't like the idea of giving up control because they're used to calling the doctor and getting whatever they want. Now they have to call us. Even some of the therapists bucked a little bit. They said that that's out of our legal preview to do this, but we assured them that with the doctor co-signing that we were all doing everything legal. A few doctors gave us a problem, not wanting to change the way they ordered stuff. It was something new, and then generally speaking, some people just don't like to change. I'm rushed for time, but the final outcome is it's been great for the hospital. Therapists love it because they can actually do what they were trained to do instead of just following an order. So it gave job satisfaction. Now patients don't have to wait for hours for the physicians to come in and see them before they get their treatment started. We go in and see them, start their treatment immediately, and then the physician may get around to them a little bit later to do their admission. All that's already been taken care of. Thank you.